Greetings from Hetero.
Yeah, good evening.
I'm Dr. Prashant. Welcome you all to this webinar, Difficult to Treat Autoimmune Diseases. Dr. As you know, Hetero is an innovative pharmaceutical company marketing products in multiple therapy areas. Besides dermatology, we market products in ortho, respiratory, and women's health, and so on. We have a very strong R&D and we have developed products based on patients' need. Doctors, we market NSAID patches to improve patient compliance and ultimately treatment outcome. We were marketing favipiravir, remdesivir during COVID time, and we market today luliconazole lotion with a film-forming technology, ultimately to stay on the skin for a longer time and improve clinical outcomes. Today, I have the pleasure of inviting moderator for today's meeting, Senior Dermatologist Dr. Saple. It's a great honor for me to introduce Dr. Saple because Dr. Saple is my teacher. And when we were crawling in medical era in 1974 and 76, Dr. Saple held our hand and made us walk. Thank you, sir, and it's a pleasure introducing you. Dr. Saple, as we all know, is honorary professor, head department, dermatology, venereology, nephrology, retired, Grand Medical College, and Sir JJ Group of Hospitals, Mumbai. He's a consultant in dermatovenerology, nephrology, and HIV, Rich Candy Hospital, SL Raheja Hospital, Fortis Associate, Mumbai. Dr. Saple is a trainer for fellowship program in HIV/AIDS IDVL. Sir is ex-president IDVL Maharashtra branch, member of IDVL SIG for dermatophytosis since 2 years, ex-president College of Physicians and Surgeons, CPS Mumbai. Dr. Saple has delivered 1170 lectures across the country and represented the country at over 108 international events. Dr. Saple is an editorial board member, IDVL Textbook of Dermatology, and has got 45 plus peer-reviewed publications, chapters in medical textbooks, 55 plus papers published in international conferences. Dr. Saple has organized conferences in national conferences, HIV, AIDS therapy, national conferences HIV and STD in 1998, HIV and AIDS in 2007, 9, 11, 13, and 15. With international collaboration in academic research with Harvard School of Public Health, Johns Hopkins University, University of Yale, University of Toyama and Osaka, University of Kuala Natal, University of Roma, amongst many others. Dr. Saple has received Lifetime Achievement Award conferred by Indian Medical Association in 2017, Lifetime Achievement Award conferred by Indian Association of Dermatology, Venerology and Nephrologists, IDVL in 2018, Maharashtra. He has got the Best Practitioner Award at Dermacon International Conference 2019 held at Bengaluru. The recent publication, Dr. Saple has published recently an open-label single-arm pilot study of fluconazole 150 milligrams in patients suffering from tinea prostans and tinea corporis. Dr. Saple is especially interested in psoriasis, atopic dermatitis, and urticaria. With this, I welcome Dr. Saple. Welcome, sir.
Over to you. Thank you, Prashant, for the nice and such a long introduction. I think we should cut it down so that we can utilize time for more for discussion. Just give me 1 second to share my slide.
Hello.
Yeah. I'm just saying what is. Yeah. Okay, I'll start.
I think there's a problem in my this thing.
It's okay now. It's okay.
It's okay, sir. It is visible.
Yeah. It's okay. It's visible, no?
Yes, sir.
Yeah.
But it's not visible.
Pardon?
In my this thing, I can't see you. Can you see me?
No,
sir, we can see you, sir.
No.
Can I be visible?
Giridhar, you have to help them.
Am I visible?
Yes, sir. You are visible. Sir, you
Am
are
I visible?
visible as well as audible,
Yes,
sir. Your audio and video is very clear.
Dr. Sinha,
Okay.
you are visible and audible both.
Yeah. So, good evening to everybody.
Yes, sir. Good evening.
Yeah.
Good evening.
Today I'm going to discuss about immunosuppressive drugs we are using in our dermatology practice. And all of us, we know that it's very difficult to use these drugs. It was the initial, but now last 8-9 years we are using it and now are getting used to it. and we have learned how to use them. But today we are going to specially talk about the particular novel drug that is tofacitinib. So today we have two panelists, Dr. Rohan Bhattacharjee. He is Associate Professor of JIMSH, Durgapur, West Bengal. He has the honor of getting scholarship for World Congress on Dermatology last year, that is Singapore. He has got other scholarship and a recipient of Ideal West Bengal Presidential Gold Medal. And he has got special interest in pediatric dermatology, urticaria, atopic dermatitis, and procedural dermatology. So we have young, enthusiastic dermatologist Dr. Rohan with us as a panelist. Second panelist is Dr. Sinha. Dr. Tapas Sinha is a very senior person practicing for last 40 years, and he has got special interest in allergic skin disease, acne, fungal infection, hairs and nails. But I was talking with him. He sees at least 2 to 3 patients of vitiligo every day. So when the discussion comes on vitiligo, we are going to exploit his experience for our knowledge. So we have got Dr. Tapas Sinha as a second panelist. So we'll start we know that immunosuppressive drugs, many dermatologists, they are scared. The reason being, I can tell you what I'm dealing because I am a HIV clinician. Because of HIV, we have learned internal medicine. So unfortunately, in our country, we get MD dermatology registered immediately after passing MBBS. But many other countries, they do general medicine. After doing MD general medicine, they get registered for dermatology. So they are better compared to us. But HIV clinician, we all understand, we have learned the internal medicine because we are dealing with all system, neurology, liver, kidney, cardiac condition. So we find it very easy to use these drugs, but of course, it's not difficult. So today we are going to discuss about immunosuppressive drugs in dermatology. So Dr. Sinha, I think first question I'll ask you, what are the immunosuppressive drugs you are using in your practice?
Actually, previously I used to methotrexate since a long, actually about 10 years back.
Yeah.
But as soon as this tofacitinib came in the market, so I have started with that. But
just
after
mention the
using,
name and then we'll discuss. Just mention. So you're using methotrexate, you're using tofacitinib, any other drug are you using in your practice?
no, yeah, I used to use only methotrexate.
Yeah, okay.
Along with the coverage of liver and all.
Yes.
Coverage was given.
Yes, okay. Just name it. I'll go to Dr. Rohan. What about you? What are the drugs you're using?
Yeah, right, sir. Thank you, Saple, sir, for the introduction.
Yeah.
So, first of all, the most commonly used immunosuppressive in my clinic is, of course, systemic steroid.
Yeah.
Other than that, I commonly use methotrexate, azathioprine, cyclosporine, mycophenolate mofetil, and also tofacitinib of late.
Okay. Yeah, so these are the drugs you are using it. So there are many drugs and it's not possible to discuss each and every drug. It will go, means we get a lot of distraction. So today we are going to discuss about what you call the novel drug in dermatology, that is tofacitinib.
Yes, sir.
So today we're going to discuss about the Indian experience about use of tofacitinib in dermatology. So we'll go directly for the discussion. I'll just introduce this drug. It is a new molecularly targeted therapeutics. Now everything they think of targeted therapeutics more than anything. So it's a transducer and activator of transcriptions. At the same time, in the intracellular signaling pathway of cytokine. And many inflammatory dermatosis, which depends upon intracellular signaling pathway, they need these mediators. And if you block this, what is called a JAK inhibitors, inhibition of the JAK pathway will be able to manage this inflammatory dermatosis in our practice. So what is these JAK inhibitors? if you look here, JAK inhibitor is inhibit the activity of one or more of the Janus kinase family, that is JAK1, JAK2, JAK3, and therefore interfering with JAK-STAT signaling pathway in lymphocytes. It interferes with JAK and STAT signaling pathway, but is the immunomodulators, which is we are going to use in our practice. So what is it, JAK-STAT? For example, for any inflammation, there has to be production of cytokines. This cytokines production, the process starts whenever there is any antigen. The inside the cells, cytokines gets activated. So when these cytokines gets activated and they combine with the antigen and these receptors, there is a what you call is a JAK, which gets activated, or what you call phosphorylation. With the phosphorylation JAK, it gets attached to STAT. And the further phosphorylation, JAK and STAT, they combine together, they form what is called dimer. These dimers get translocation in the nucleus and start new transcription and starts producing more cytokines. So more cytokines, more inflammation. If you block JAK, there is no production cytokine, no inflammation. This is the mode of action. I think Dr. Sinha, can you keep on mute? Yeah, put on the mute. Yeah. So this is the mode of action. So what are the JAK inhibitors? There are many JAK inhibitors. That is tofacitinib, ruxolitinib, baricitinib, oclacitinib. There are many. Tobracitinib, many are there. But today we are going to discuss about tofacitinib. So Dr. Rohan, what are the indications you are using tofacitinib?
Thank you, sir. So the first and the foremost indication for which tofacitinib was FDA approved and for which I most commonly use tofacitinib is alopecia areata.
Yes, correct. That's right.
So for alopecia areata, be it alopecia subtotalis or maybe a local single patch of alopecia areata, if it is not responding to the conventional treatment paradigm, I usually shift to tofacitinib, either topical, and if it is involving more than 50% of scalp, I usually go for systemic tofacitinib also.
Okay. Yeah. So one is alopecia. Any other indication are you using it?
Other than alopecia areata, I commonly use it for palmoplantar psoriasis also, sir.
Okay.
Palmoplantar psoriasis, and other than that, even vitiligo vulgaris.
Okay.
Vitiligo vulgaris, which is spreading very fast, I have used in those kind of cases also, sir.
Dr. Sinha, what about you? What conditions you are using this in your practice? Dr. Sinha. Giridhar, can you help Dr. Sinha?
Yeah, it is from.
Yeah. So there are indications according to literature. This drug is used, as you said, it has been approved by FDA for alopecia areata, psoriatic arthritis.
Right.
Of course, these are the conditions, but usually the commonly used in atopic dermatitis and vitiligo. So these are the 4 conditions it has been used. Of course, they target this, what is called interleukin in each and every condition, like atopic dermatitis. It is targeted interleukin 4, interleukin 5, and interleukin 13. Now they talk about interleukin 31 for the itching. Then alopecia areata is the interleukin 15 and interferon. These are blocked. In psoriasis, of course, interleukin 12, 23, and even 17. But 17 is with the secukinumab more than this. Then the vitiligo. So these are the conditions where it is commonly used. But Dr. Rohan, what are the other indications where it can be used? Offline.
Yeah, right, sir. So off-label, I have used tofacitinib for even lichen planus. I've used it for erythema nodosum. And also, other than that, I have also used it for oral lichen planus per se, in which I used a swish and spit method.
Okay. Yeah, I agree with you. There are many indications. Dr. Sinha, are you online? Giridhar, can you help Dr. Sinha?
Yeah, I'm asking to unmute, but
Uh,
Dr. Sinha is not
just
letting
help
us.
him, just help him.
I think you can give him a call, voice call, so that he can unmute.
Sir, I spoke to him. You can continue, sir. He has some technical issue. He will join
Okay,
in some time.
anyway. So there are
Right.
indication, there are small case series where they can use in dermatomyositis, chronic acting dermatitis, erythema multiforme, lupus, and so many others.
Right,
And
sir.
anecdotal reports also for allergic contact dermatitis, B cell mediated chronic cutaneous lupus, as Rohan has mentioned. These are the off-label indication. We can use it. Only thing we have to be careful, and we have to see that this should not be first line of treatment. When
Absolutely, sir.
whatever the available drugs are failed or not working, we can use these drugs.
Absolutely.
Yeah, so we'll go for the case studies. This is a patient of psoriasis, Rohan,
Yes,
45
sir.
male patient with a chronic plaque psoriasis suffering for 5 years. He has got a comorbidity, that diabetes, hypertension, and he's on diabetic and anti-hypertensive drugs. When he came, of course, he started with the topical, but such a extensive lesions, topical, you agree that is not enough, and
Right.
patient will not be happy. So we started this patient on cyclosporine, because that is the drug we said is the most effective and the drug for the rescue therapy.
Absolutely.
So we started with cyclosporine 100 milligram BID, and then we tapered to 100 milligram. Patient was doing very well. But you know that one of the untoward side effects of the cyclosporine is hypertension and serum creatinine. So if blood pressure
Right.
starts rising, and there is a rising of the creatinine. So now what you will do, Rohan? This patient you are treating in your clinic, and
Right,
he has
sir.
started showing the renal involvement, increasing blood pressure. What you will do now to this patient?
Right, sir.
Yeah.
So I totally agree with your approach of starting cyclosporine in this patient, because it gives wonderful results in the initial few days, definitely. But since we are seeing the side effects like hypertension and now probably distorted creatinine clearance, so I think we have to be very careful now with the drug. In this case, actually, we can continue cyclosporine but at a tapered dose, because if we are able to control the blood pressure using some antihypertensive, and if it is getting controlled, then we can continue cyclosporine at probably 3.5 milligram per kg body weight. Regarding the creatinine rise, I think 1.2 to 1.36. So unless and until there is a very significant rise in creatinine, we need not be very much worried about it. So what I would like to do is I would like to stop cyclosporine for some days and then repeat the creatinine serum creatinine level, and then maybe measure the blood pressure again. If everything is normal, then I would like to restart cyclosporine at a lower dose and then monitor the patient again.
I entirely agree. You lower the dose, and if you can manage it, you can continue.
Wonderful, sir.
Yeah, but if there is no good response and still
Yeah.
the patient is already on anti-hypertension,
Right,
and if
sir.
there is another option, we can change it. So what we
Yes,
did,
yes.
Rohan, we
Yes, sir.
changed it to methotrexate.
Okay, sir.
Yeah.
Yeah, absolutely. Methotrexate
Yeah,
can
this
definitely be
is-
started.
Yeah. Dr. Sinha, are you available? Okay, so methotrexate we shifted, but unfortunately again, it developed hematological toxicity, that leukocytopenia, so we have to discontinue.
Right, sir.
Yeah, so now what you will do?
Very tricky situation, sir, because the patient is not able to tolerate methotrexate,
Yes,
and
yes.
cyclosporine is also out of the box now.
Yeah,
So in this patient, probably I would like to give a trial of apremilast, sir.
yeah, okay, yeah. So
Ap-
we can start apremilast, but you know that apremilast many times, I think,
Yeah.
according to me, it works only 10%.
Yes, it is an all or none phenomenon. Either it
Yeah,
works or it
yes,
does not
correct,
work.
correct, yeah.
Absolutely, sir. Absolutely, I
Yeah,
agree
so
with
we
you.
are not sure whether it will work or not, but we should give a trial. I entirely agree.
Right,
It
sir.
works very well. But
Yeah.
you know what we did? We started this. This is about, I'm talking about 4.5 years before.
Right,
I
sir.
started this patient on tofacitinib 5 milligram BID
Right, sir.
with thorough evaluations. Of course, by giving these all require this before starting, what are the monitoring should be done.
Yes.
And see, after 4 weeks, I was surprised to see that everything was cleared.
Right, sir.
And since then, I'm using tofacitinib where there is no other option is available.
Right, sir.
Uh,
Sir, I just have one question here, sir.
yeah,
For
yeah.
how long did you continue tofacitinib in this patient?
See, this is a very good question because how long we should continue, because the tofacitinib is one of the drawback. When you stop it, there are chances of relapse,
Relapse.
or recurrence. I entirely agree. But this patient, we use it for 2 years.
Okay.
continuously, and in the tapering doses. And after that, there was a remission. I'm following that patient for last 4 years, and he has
Okay.
good remission.
So after stopping tofacitinib, have you restarted the patient on any other systemic therapy, or is he maintained only on topicals?
Not this patient, but you raised very good patients. Many other patients, you are switching over to methotrexate.
Again,
But
yes, sir.
many patients can't afford, so we are switching them to methotrexate.
Right,
It's
sir.
It's a good question. Very nice of you. Yeah.
Right, sir.
So now the next question comes, as we agree, cyclosporine is one of the drug for the rescue. Because when a patient comes, they want immediate relief,
Absolutely.
They should improve within 2 weeks, 3 weeks. So this is another patient we started on tofacitinib, and see after 2 weeks there is very good improvement. See the lesions on the hip joint, lesions on the elbow area and the lower back, which is the common side for. So because that was I wanted to try, and then I realized this drug is also can be useful. So in psoriasis, at least I'm happy last 4.5 years, so
Right, sir.
much that I'm tend to use this drug, but we have to be careful.
Yes, sir.
Monitoring will come to the later.
Yes, sir.
This is Rohan, another patient
Right,
of
sir.
muscular psoriasis. You can make out this lot of lack of pus, and the erythema. There is involvement, eyes, systemic involvement. But again, this patient is having hypertension and diabetes both. She is an old lady. So we admitted this patient, and of course, the drug of choice is a systemic steroid. But a
Right, sir.
patient with diabetes, hypertension, how long we can continue? So how you're going to manage this patient? Because initially, okay, till we control, we can give steroid, but we can't continue steroid for long.
Absolutely,
Yeah,
sir.
yeah.
Absolutely. Sir, keeping in mind the clinical scenario of pustular psoriasis, and she's an old lady
Yes,
who
correct.
has diabetes, and I am assuming that she has uncontrolled hypertension also.
Yeah.
So in this case, if she was not hypertensive, I would have definitely gone for cyclosporine, sir. But since there is hypertension, I would like to try acitretin in such kind of cases.
Yes, absolutely correct. Yeah, acitretin is one of the drug of choice, but she had a dyslipidemia also, which was
Okay,
also
sir.
uncontrolled. Yeah.
Right, sir.
Hmm.
So in this kind of case, patients, I think I would like to try tofacitinib, sir. Although I have limited experience
Yes,
with
yeah.
tofacitinib in pustular psoriasis, but I
Yeah.
think we can give it a try.
Yeah, okay. So, of course, nowadays pesolimab is available on the extended
Right.
clinical trials, but those days it was not there. So, as you mentioned, I said, let us taper the steroids and continue tofacitinib. And I'm following her for last 40 months. That is more than
Okay.
3 years.
Wonderful.
And now she's on 5 milligram tofacitinib once in a week without any side effects. And you can see this, 45 months, more than 40 months,
Wonderful.
almost. And she's doing very well. And I'm happy, she's happy, but in a tapering dose, and now dose is 5 milligram once in a week. So
Right.
my message is initially can start. Usually the dose according to what literature is given 5 milligram BID, but most of time in the acute cases, I start with 10 milligram BID, that is 2 BID.
Okay.
And initially one patient comes under control, we can start tapering. Only thing when
Okay.
you're starting the higher dose, you have to be very careful about the bone marrow. So every
Right, sir.
week I get CBC done if something is going on wrong. It has to be closely monitored if the patient is starting with a higher dose.
Sir, I have a question that for
Yeah.
how long did you continue 10 milligram BD in this patient?
Yeah, see, 2 weeks, initially for 2 weeks. And 2 weeks, disease comes under control, then we make 3 tablets. The next, every 2 weeks, we keep on tapering. If the disease
Okay.
is under control, disease is not controlled, some patient have continue for 3 weeks to 1 month. But
Right,
we
sir.
again mentioning monitoring of CBC.
Right, sir. Sir, on
Yeah.
the same topic, I would like to ask, what would you have done if at that time we had extended release 11 milligrams available?
Yeah, extended is available. Then you can give 1 BID instead of 2 BID. Yeah, but
Okay.
I have not used that 11 milligram when I giving 2 BID, but for
Right, sir.
maintenance we can use it.
Okay, sir.
Yeah,
Okay.
yeah, correct. So there are clinical trials. There are a lot of clinical trials about the psoriasis. 339 clinical trials across the globe. And the summary of that, 75% improvement in psoriasis, body surface area and severity is seen. So they say this is one of the wonderful drug in psoriasis. But again, I'm mentioning we have to monitor it very closely.
Right.
And yeah. So these are the studies they have used in psoriasis, and the message tofacitinib, they have given about 12 weeks, and they found when you give 5 milligram, the result is less. But when you give 10 milligram, more percent, 63% of the patients start responding. So higher doses are good initially, but it is, of course, the literature, there are many people are using this. There are a lot of studies, and I feel we should use higher doses initially. And there are
Okay.
another studies shows tofacitinib is non-inferior to
Etanercept.
etanercept. That is a biological. So this is one of the good drug. But now is a topical is available. Topical ruxolitinib is, they said, better. But in our country, we have got tofacitinib 2%, ointment and gel. But we can use it in their limited number of patches.
Right, sir. Right, sir.
Yeah, okay.
Yes,
So
sir. Maybe in case of palmoplantar psoriasis, we can definitely
yes,
try
correct. Yeah,
topical tofacitinib.
restricted area. Yes, very good. So, Rohan, any other information or any question on psoriasis?
No, I would just like to add, sir, that I have used tofacitinib 5 milligrams BD for a lot of cases of isolated scalp psoriasis, also sebopsoriasis,
Yes.
many of the cases, and I've seen really wonderful results, sir.
Yeah.
Almost total clearance within 2 weeks.
No, that is a good thing. You are sharing your experience with this point is because there are what you call recalcitrant psoriasis.
Yes, absolutely.
Palmoplantar, non-responding plaque psoriasis, scalp psoriasis. The recalcitrant psoriasis, the nail psoriasis, is one of the good drug, as you said. I also am using in recalcitrant, and we are getting good results.
Right, sir.
Yeah. Then I think we'll go for the next topic, that is
Sure.
atopic dermatitis. This is a patient of atopic dermatitis of a 55 years old male patient. He was on corticosteroid for 1 year. He was referred to me from Lucknow. And again, once you cross 45, you start with landing with the comorbidity. So again,
Right,
he had hypertension, he had undergone angioplasty. Of course, there was no diabetes. So again, I started with cyclosporine.
Right.
But same thing happened with the blood pressure. Then switched to methotrexate. Then, of course, somebody has given acetated, but he has got a dyslipidemia. Then he was started on adalimumab given, but he said, now there is a recurrence. So now, what you would like to start in this patient?
Sir, since all the major biologicals have either developed side effects or failed in this patient, then we have to definitely try for something unconventional in this patient. Maybe initially, before going to tofacitinib, I would like to give a small trial of apremilast also, sir.
Yes.
Because there are few case reports in which atopic dermatitis responds to apremilast.
Yes, correct.
But in case if the patient does not respond, then I would like to try tofacitinib because there are good case reports and the results are good actually.
Yeah, of course. Now abrocitinib is available.
Absolutely,
Very, very expensive.
Yes.
Anyway, but this patient has taken adalimumab. We could have given, but this is again 4 years old patient. Yeah, so very few patient can afford abrocitinib.
Absolutely, sir.
Yeah, so we started patient on this tofacitinib, and within 15 days, he phoned me, why you are not started this drug earlier? Of course, this was not available. I explained to him, but after 1 month, he phoned me, sir, I'm getting body ache. My whole muscles are aching. So now, Rohan, what do you think? Because when you are using tofacitinib, we are going to face their side effects.
Yes, absolutely, sir.
Yeah,
So
yeah.
one of the reported side effects of tofacitinib is myositis. It can cause
Yes.
myalgias
Mm.
and probably myositis also in some cases.
Yeah.
There are few case reports in which there are elevations of CPK-MB.
Yes, correct.
So we have to be really careful when patient complains of these side effects, and we need to really not ignore this side effect and take heed of this, sir.
Mm.
So probably, yeah. So I
yeah.
would like to know, how did you manage this, sir?
Yes,
Because
correct,
yeah.
yeah. No, I entirely agree with you. I also suspected that probably we are dealing with the rhabdomyolysis. That is one of the side effects.
Side effects of
As you said, the
tofacitinib.
myositis. So what I did, I got, as you mentioned, the CKB and the serum aldolase, because usually serum aldolase is also raised,
Yes.
in any muscles involvement.
Absolutely.
So both were normal, but we should not hesitate. I'm being a senior dermatologist, because we have to learn from the younger people also. So who are the more experienced people? The rheumatologists, they're using this drug 3-4
Yes.
years earlier than us. So I
Right.
put one of the rheumatologists. So that rheumatologist, he told me, sir, it's very simple, not to worry. I said, why? He said, you are using rifampicin leprosy, what happened? You get flu-like syndrome.
Yeah.
The same thing can get after 1 month or 6 weeks or even earlier than that. You don't worry, your CPK is normal, LDH is normal, go ahead, because only you can lower the dose, and this is how we did it. But as you said, I was worried about, because I was also new in tofacitinib.
Right, sir.
Yeah, about the myositis or involvement of the muscles. But we continue this patient. Now we'll take another patient. This is a patient of Pomfalix. Again, this is the old lady. Again, she used steroid, she used cyclosporine drug, but she was getting repeatedly. So I said, why not to start tofacitinib? We started tofacitinib, but again, as you said, she is taking this tofacitinib for last 2 years. So it is a long period, a prolonged period we have to give. This is another patient. Of course, again, if you see that the dose is higher, results are better according to the trial.
Okay.
Yeah, and there are 19 clinical study across the world, and they say is an innovative drug for the treatment of atopic dermatitis.
Atopic dermatitis.
Yeah.
Sir, on this very note, I would like to ask you, how is your experience with topical crisaborole, sir? I know it's very off topic, but yeah.
Yeah, crisaborole I'm using only for maintenance therapy for the long term. But the way patient comes with the acute episodes, we have to use one of the aggressive therapy, either cyclosporine, you have to use it, steroid, you have to use it, or nowadays I'm very happy with the tofacitinib, so I'm using tofacitinib. Yeah, and then switch over to maintenance therapy. So crisaborole I'm using as a maintenance therapy.
Right, sir.
What is your experience, Rohan?
Sir, crisaborole, I have a very mixed review about crisaborole.
Yeah.
So in acute phase, I don't think it is possible to use crisaborole,
Yes,
because it
correct.
causes a lot of irritation over the acute weeping lesions.
Yes, correct.
And even over the chronic lichenified lesions, many of the patients, they will have constant excoriation and erosion over those areas. So the response to the review that I have got is a very mixed one. So as you said, maybe after the patient is totally free of any kind of erosions or active lesions, then we can go ahead and keep the patient on crisaborole as a steroid sparing agent,
Yeah,
similar
correct.
to tacrolimus.
Yeah, absolutely right. Yeah. So now this in adult. So many cases we are using when there are no other options or you want. But now I think that was in adult, but now we are talking about, I'm seeing the case. Can you see this patient? She's restless, she's not able to sleep whole nights,
Right.
and the school, she cannot go to school, she cannot concentrate. More than her, their parents are more
Parents are
worried.
disturbed.
In fact,
Yeah.
her mother is going to depression. Yeah. So this is the patient. Yeah. So she came to my clinic. Of course, she's a 6-year-old female. And if you see, initially she was given azithromycin when she came our clinic, and syrup cyclosporin. But with cyclosporin, she started getting excessive hair growth. Then we switch over to, of course, betnesol. But betnesol, she started getting constipation. Her weight gain was so much. 6-year-old girl, she started telling me, doctor, in my class, nobody is able to recognize me. She has put on so much weight. So now how are you going to manage this patient?
So this patient needs rapid improvement, sir. As I can see from the video, she is very
Yeah.
restless and
Yeah.
but it's hampering her normal daily
Yeah.
lifestyle. So,
Yeah.
as you have mentioned, one of the very important side effects of cyclosporin, the hirsutism. She's a female,
Yeah.
and that's unacceptable totally, because once she grows up, it's going to be a real problem. And as far as the weight is concerned, we cannot even go for the steroids. So I
Yeah.
think for her, we can definitely start tofacitinib. It will be a wonderful option because she needs rapid improvement.
Yeah,
So
so as you suggested, we started with the syrup topacitinib. After 6 years, we can use it. You
yes,
know, so we started with the 4 milligram. This is the picture before, initially, how she was looking. Yeah, but this is, can you say, after 1 month,
wonderful,
everything cleared.
wonderful results.
See, the back, and she's doing very well. She's under my treatment for last 8 months, and we are monitoring very closely. So
Wonderful,
with
sir.
the tofacitin, we are getting good result with the children also. We cannot show all picture, but this is one of the patient. So shall we go for the next topic now?
Yes, absolutely, sir.
Yeah, yeah. So atopic dermatitis is one of the wonderful drug, but again, I am mentioning we have to monitor it very carefully. See, this is the patient. He came to my clinic. Again, he has used all immunosuppressive drugs, whatever are available in our dermatology practice. But he said, doctor, I have used all these drugs. Do you have anything else? Then this patient has started on tofacitinib. And see, after 2 weeks, there was good hair growth. Patients were very happy. After 3 months, he was really surprised and he was shocked that he got all this. Yeah. But
Yes, sir.
Rohan, you know, this patient of alopecia areata, alopecia totalis, when they come, we start these drugs, any immunosuppressive drugs, they do well, they improve. But in tofacitinib, the minute you stop it, they start losing again.
Losing the hair.
Yeah.
Absolutely, absolutely right, sir.
Yeah. So how you are going to manage this patient?
So for tofacitinib of late has become one of my favorite drugs for alopecia totalis particularly. So instead of jumping to steroids, I straight away jump to tofacitinib because of the faster result.
Yes.
But as you mentioned, sir, once we stop or start tapering it, the patient starts losing hair again. That's a big problem. So I normally what I do is as I start tapering off tofacitinib, before that itself, I start the patient on something else, some other immunosuppressant also, so that there is an overlap and the other immunosuppressant gets some time to kick in the action. I usually go for methotrexate at a lower dose and slowly hike it up. And sometimes I even go for azathioprine at a lower dose because we know azathioprine is also a bone marrow suppressant and tofacitinib can also cause bone marrow suppression.
Yes, correct.
So yeah, so I usually go for these two drugs for maintenance because in my experience, I have used tofacitinib maximum of for a year in case of alopecia. And after that, the patient started developing some derangements. So I have started the patient on methotrexate and I got good results. I won't say the hair was as good as when the patient was on tofacitinib, but
Yes, correct,
even
correct.
after I have stopped it and maintained the patient on methotrexate, what I felt is probably tofacitinib made the patient more responsive to methotrexate.
Yes, correct. So, you know, there are a lot of, in fact, if you interact with the rheumatologists, they combine tofacitinib and methotrexate. The combination works very well.
Absolutely.
So you can combine this drug and slowly can taper tofacitinib and you can maintain on methotrexate. Because I entirely agree, most of the people are using methotrexate as a maintenance drugs in this. And I've used this tofacitinib at least for 2 years and then switch over to, yeah, but sometimes I combine this early. If the patient agree, we combine it early with the methotrexate and and taper this tofacitinib as early as possible. But again, with the methotrexate, also you have to monitor
Right, sir.
CBC, liver, and serum creatinine.
Yes,
Yeah.
sir. Sir, I have a few questions here for you.
Yeah.
One thing what I would like to ask is many of these cases of alopecia totalis actually they have a very long history. Have been suffering with this for quite some time.
Yes.
So when you start them on tofacitinib, minimum for how many months do you wait till you see the results?
Yes,
Or
correct.
yeah.
Correct. Here you have to wait minimum 6 weeks to 2 months. You're
Okay.
absolutely right. Yeah.
Yeah.
Because I had one patient, he has lost his eyelashes. Yeah, he lost his eyelashes. His other part he started the hair growth in the scalp, other part, but eyelashes were not growing. So he was looking, of course, he said, I'm not happy. But then I saw the literature where they say for the eyelashes, it takes minimum 3 months. After 3 months, you start growing, you know. So
Right, sir.
it takes longer time. As you said, we have to wait.
We have to counsel the patient that way. That
Yes, correct, absolutely.
sometimes you have to wait. Yeah.
Yeah.
Right, sir.
So there are 254 clinical studies across the globe, and they found this is also one of the wonderful drug for alopecia. But now the question comes when we should give systemic and when should give topical, because now topical is also available, correct?
Right, sir.
Yeah.
So normally for topical, I usually, if the patient is having 1 or 2 patches over the scalp, or maybe beard or mustache involvement, and that to a very limited area, maybe less than 20%, then I usually go for topicals. If I feel there is something more than 20% involvement, because the patient finds it really cumbersome to apply.
Yes, correct.
So, and patient needs immediate results. Otherwise, patient starts losing faith on the medication itself. So if it's less than 20% involvement, I usually go for topical, sir. Also for eyebrow involvement, I have seen topical tofacitinib works really good.
Yes, correct. I entirely agree. See, initially I was under assumption of the impression, what you say, when there is many patches of alopecia areata, large patches of alopecia areata, the topical may not work because there are more antibodies. And to suppress the antibody, you have to give systemic drugs. So first 2 years, I did not use topical at all.
Okay, sir.
But then I learned from the patient, I'm going to show patient. See, okay. These are the studies there, as you said, discontinuation of the drug lead to loss of hair. This lady came to my clinic. She is 75 years old lady. And she came with the hair loss. She said, I want hair back. I said, you have to take systemic drug. She said, no, don't give anything. If you have got any application, give it to me. Yeah, because, you know, many people are worried about the side effects. They are living long. Correct, no?
Yes.
He said, let us try. And I started with tofacitinib, 2%. And see, of course, her hemoglobin that time was also less. But the first thing I did it, because this looks like it can be because of the aging process, correct?
Yes, sir.
Not necessarily the alopecia aging process, or it can be female pattern hair loss.
Hair loss.
Yeah, so first we did a biopsy because I wanted to know what is it. And see, biopsy came alopecia areata, active lesions. It was very special. And that's why we started tofacitinib. Of course, we gave supplement of the iron. We increase your food intake. We counsel for the diet. And after 2 months, there was a dramatic improvement. See, I'll show the picture. See, this is a picture after 2 months.
Great.
Yeah, I mean, you know, there are many things we take as assuming, you know, take it. So that's why we need some clinical trial and
Absolutely,
more
sir.
clinical experience. So that's why I was talking to Hetero. More than clinical trial, we'll discuss what are the cases are improved, you know.
Right, sir.
That will give
Sir, just one point to add here, sir. I really appreciate that she applied topical tofacitinib and got so wonderful results.
Yeah.
Just I wanted to ask that won't topical tofacitinib for such a large surface area be more expensive to her as compared to systemic?
Yes, correct. Entirely, this is a very important point. Everybody can't afford.
Yes,
But
sir.
this patient was affording. Yeah,
Yeah. Yeah.
I
Right,
agree
sir.
with you. Yeah,
Right, sir.
good point.
Uh,
Yeah.
Just one more question, sir. Did you
Yeah.
ask her to apply it OD or BD?
Pardon?
Was she applying the tofacitinib gel once daily or twice daily, sir?
No, twice in a day.
Twice daily.
Yeah, correct.
Right, sir. Right, sir. Thank you,
Yeah.
sir.
Yeah, okay. So that was about alopecia areata. So after that, of course, after that, I am started using this, and now I'm confident the topical application is very good and is very effective. Now in many patients, I do not give systemic drugs because I have developed that confidence of
Wonderful,
giving
sir.
topical. Yeah, when there are contraindication, we can't, if the patient doesn't want, we can, yeah.
That's a very great takeaway point, sir. I
Yeah,
will
because
definitely try it out.
yeah, you try it on and share me your experience after 6 months.
Absolutely.
Huh?
Absolutely, sir.
Yeah, Rohan, this is another patient. He came with this plaque psoriasis. I started on tofacitinib, but he came with he said, sir, I'm losing hair. So is it related to tofacitinib? So this is he sent me these pictures on mobile. So when you look at this picture, what do you think? Is it because of tofacitinib or?
By the pictures, sir, it looks like grade 3V of Norwood Hamilton male
Yes,
pattern baldness, sir.
correct. Even I thought same thing we are doing with male pattern hair loss.
Yeah.
But he immediately, I said, it looks like family history is there. I asked, but they said, I'm losing these bunches like this. The many ladies, they come to your clinic.
Yeah,
with
yeah.
Yeah.
Right.
So in the drug related or drug induced hair loss cannot be in bunches like this. No.
No, sir.
Yeah. So what do you think this is?
This is quite tricky, sir, to answer because I've not
Yes,
encountered any patient with
Yeah.
this side effect till now.
Correct. Same thing with us. We are also learning. Then we have got a habit of asking any patient come with a hair loss since COVID-19.
Yeah.
We ask this history of. Then we ask this. He had a COVID about 2 months ago, and you know
Okay.
that this is one of the COVID
Side effect.
This is one of the common cause of the hair loss.
Yes, absolutely, sir.
History is very important. So it's probably is a telogen
Acute
effluent.
telogen effluvium.
Yeah, correct.
Right,
Yeah. This I'm just showing because we are talking about tofacitinib all the time.
Right, sir.
Yes,
Because
correct.
patient may start attributing it to the drug.
Yes, correct.
So that's a very important point to be pondered upon. Right, sir.
Yes, correct. Then this is the case of lichen planus. I'll go a little bit faster. This patient again is the old patient, but she had used all drugs, whatever methotrexate, steroid, azathioprine, cyclosporin, everything she had. But when she came to me, it was hypertrophic lichen planus. Because of hypertrophic lichen planus, we did a biopsy. Biopsy shows hypertrophic lichen planus, a pseudo carcinomatous hyperplasia.
Okay.
Yeah, so we started on tofacitinib and she was doing very well. But after 3 months, she complained of that, doctor, I'm getting swelling of the leg, unilateral, and is very painful. So what do you think? Because these are the cases we are going to face it.
Yeah, absolutely, sir. So in this patient, was she diabetic, sir?
No, she was not diabetic.
She was not diabetic.
She
The
was
first thing the first thing that would come to my mind is definitely cellulitis, sir, in this kind of patient.
You're absolutely right. This was cellulitis. So next question comes, how you are going to manage? Are you going to continue tofacitinib or are you going to stop it?
Sir, because I have not encountered any patient with cellulitis, but yeah, I have come across patient who developed COVID infection while being on tofacitinib. So in those patients, I have stopped tofacitinib for that duration and then restarted after 3 months again. So for this patient, I think I would like to stop tofacitinib for some time and then start her on systemic antibiotics and then restart once she settles down.
Yeah, I agree. Wherever there is any acute infection or active infection, any active infection, you have to stop tofacitinib.
Stop, right, sir.
Yeah, but in this patient, then we treated with linezolidine. Patient became all right. After 2 weeks, we started with the lower doses.
Lower dosage of
correct.
tofacitinib.
Yeah. So what are the side effects? Now, can you mention the side effects? Some of the common side effects you have seen?
Yeah. So one of the commonest side effects which I have seen is transient pancytopenia, lower platelet counts, low TLC, and a low hemoglobin in
Yes, correct.
few of the patients, I would say.
Yes, correct, yeah.
Other than that, I have seen a few of the patients with flu-like symptoms also, because they start complaining they have more sneezing and they have a little bit of uneasiness, which recovers automatically.
Yeah.
Other than that, a few patients with probably nasopharyngitis I have encountered, and I think one patient only with varicella zoster infection.
Yeah, they have mentioned in literature nasopharyngitis is very common. Then herpes zoster in our dermatology, and as you said, the bone marrow suppression or the what is the thrombocytopenia anemia can be. These are the common, but
Yeah.
there are other side effects like myositis.
Yes,
Okay.
absolutely, sir.
Yeah, and increase, of course, dyslipidemia. One of the contraindication here is the
Is
DVT.
deep vein thrombosis.
Yeah, so where the patient comes with a previous history of venous thrombosis, patient immobilization, myocardial infarction, heart failure, these are the patient better not to start. History of malignancy or obese
Right, sir.
patient, better not to start this tofacitinib. This is a contraindication.
Right,
This
sir.
is another patient. This is one of the doctor. He came to my clinic with extensive bullous lesions. Then again, see, he has got many comorbidity. He has got a hypertension, he has got chronic renal failure, serum creatinine is 5 point, and developed pulmonary cox. When he came to my clinic, it was his Herculean task what to use it. But he
Right,
had
sir.
extensive lesions. The topicals were not much useful. So which immunosuppressive would like to use it?
Sir, since you have mentioned
Yeah.
that he's a doctor and
Yeah,
probably
he's a doctor himself. Yeah.
definitely I would. Yeah. So definitely, I do not think long-term or high-dose steroid
Yeah.
is an option, but
Yeah.
we can definitely try it.
Yes.
But one of the off-label things which I have tried and in few of the patients is omalizumab. So if the
Yeah.
patient is affordable, sometimes we can
Yeah.
start off omalizumab. It has also been mentioned.
Hmm.
But in this patient, I think I don't have experience with tofacitinib, but I think I would like to start steroids or cyclosporine first.
Yeah, I agree with you. Off
But
label.
then again, the creatinine is very high, so
Yes.
cyclosporine is definitely out of the question, sir.
Yes, correct.
So high dose steroids, otherwise,
Hmm.
which can go for tofacitinib, sir.
Yeah, previously we used to use steroid in spite of everything because there were
Yes.
no other options.
Yes.
And as you said, nowadays they say any dermatosis where IG is very high.
Right, sir.
Omalizumab is useful.
Yes,
So
sir.
people are using omalizumab for this. But again, omalizumab, rituximab, they take a little bit longer time.
Long time to act, sir.
Yeah,
Right.
longer time. Even some people have mentioned about the acitretin, tetracycline, doxycycline, but it takes longer time. So
Very
I said,
long.
let me try because even the kidneys compromised, you can use tofacitinib. So I started using of course, first I did a biopsy. It turned out to be bullous pemphigoid. Better to confirm.
Right,
So this is the patient where we got to learn or got to know about the drug-drug interaction. So of course, the tofacitinib, the metabolism with the CYP3A4. So when you are using the CYP3A4 inhibitors, these drugs, the concentration gone up, and when you're using rifampicin, the drugs is metabolized fast. So we have to be very careful what drug you're using it. So instead of rifampicin in this patient, tuberculosis, I treated with pentoxifene, sorry, no, what is this? Is a Cipla drug. How come I've forgotten? Anyway, is like amoxicillin. What is the drug used for TB? Rohan?
Is it this thing, sir? Is it clarithromycin?
No, not clarithromycin. Usually we use for the bovine tuberculosis or
Right.
resistance. Here I use moxifloxacin.
Okay, sir.
I also get blocked sometimes. Anyway, moxifloxacin instead of rifampicin, we treated with a tofacitinib, and now we have switched this drug. He is a Muslim, so we got G6PD done because that's very common among the Muslim community.
Yes.
And now his maintenance on Dapson and is doing very well.
Wonderful,
This
sir.
is a patient we treated with. Yeah. So this is the patient, another patient with bullous pemphigoid, started with, of course, rituximab plus tofacitinib. Again with the I'm showing the patient the comorbidities because where in elderly patients, other drugs are being constrained with the other drug, like cyclosporine or steroids, and these biologicals are expensive. So again, we did a biopsy. You can see the beautiful biopsy, shave biopsy, a bullous pemphigoid. But I'm not showing for this purpose. This patient, we started tofacitinib and his platelets started dropping.
Right.
Yeah. So now how you are going to manage this patient?
So in this patient, so first of all, I would like to stop tofacitinib, and maybe the patient needs some platelet infusions but I think at 84,000, he does not need an infusion. Even just stopping tofacitinib, patient will get improvement in the platelet count.
Yeah.
Right, sir.
We are being as a HIV clinician, we see thrombocytopenia very
common.
15,000, we can afford to wait. Yeah, it is because of the HIV induced or the drug induced, we can afford to wait. But as you said, transfusion is one of the treatment. So, but here, the literature and what we did, we reduced the tofacitinib. After 1 week, platelets came back to 1.6 lakhs. So
Okay.
is the dose dependent?
Dose dependent
Yes,
toxicity. Right, sir.
Yeah, is the dose dependent. But this is another. This patient was doing very well. He refused to miss. He said, I'm doing well. Why we should go to doctor? He kept on taking himself. And one day he phoned me, doctor, I'm feeling very weak. I do not have any strength. I'm not able to walk properly. I'm not able to eat properly. I said, first thing you should do is CBC. And if you look up at the CBC, see the picture is so bad. That's why they land up into the, that's why always I tell all our colleague dermatologists, this tofacitinib should not be prescribed, it should be dispensed. And I remember Dr. Fitzpatrick, he has written about methotrexate also. It has to be dispensed from the clinic so that you dispense for 2 weeks. So definitely patient has to come back. And you will be able to monitor the side effects.
Right.
Yeah. So do you agree with this message?
Absolutely, sir.
Yeah.
It has to be, it should not be very readily available for the patient to buy and eat like candies.
Yes, correct. So, and is a dose dependent. I think, can we stop or we can continue, Dr. Prashant? Dr. Prashant?
Giridhar, what is the situation?
Yeah, Dr. Saple is calling you.
Yeah, but can we continue or?
For some time, or we
So
can.
I think, Sir Manor here, I think we can take the questions which
Yes.
Yes, correct. Okay.
Sir, there are some questions. I will.
That's right. So I'll stop sharing and I think Rohan will take questions. Okay.
I will ask questions to the team. I mean,
Sir, I dropped the questions in the chat box.
Yeah. First of all, there was a question, sir. Can we give tofacitinib along with statins?
Yeah, Rohan, you would like to take it or?
Yes, definitely, sir.
Yeah.
So basically, whenever we are starting tofacitinib, we get a baseline fasting lipid profile, a total cholesterol and a triglyceride level done for patients. So if already the levels are quite high, then usually we do not start tofacitinib in the first place. But secondly, if the levels are not very high, if the triglyceride levels are not touching 500, if they are below 350, and the total cholesterol is also below 300, then we can definitely start both the drugs, a statin and a tofacitinib together, provided patient has no other option other than tofacitinib.
I entirely agree. Yeah, with Rohan. Yeah.
Yes. And then can tofacitinib be given along with steroids and other immunosuppressants co-prescribed?
Absolutely. It can be given with steroids and other immunosuppressants.
What is the duration? Of course, I've answered this question. What is the duration to which tofacitinib can be given? Maximum, how long can we continue?
I think Dr. Saple can answer this question better because
I'm using for last 4.5 years tofacitinib. You can continue for 2 years, 3 years, but you have to monitor very closely. And in the monitoring, one of the point, everybody is scared or everybody is worried about the tuberculosis. reactivation of tuberculosis. But last 4.5 years, I have not seen a single case of tuberculosis. I am a HIV clinician, where in my clinic I see 2 or 3 patients of TB even today, because I see 10 to 15 of patient of HIV every day. So TB, so I have not seen any patient of reactivation of tuberculosis last 4.5 years. But the literature says there are clinical studies that you must rule out underlying latent tuberculosis.
So do we do TB test for
Rule
every
out
patient?
latent tuberculosis. Now many people are confused. They said get an IGRA test. But IGRA test is not necessary. Montox test is
Just
enough.
a Monto test is enough. Absolutely, sir.
And chest X-ray and ESR. But don't get confused, because many times people get influenced by other, our dermatologists get influenced by other faculty very easily. But I can tell you, and then I saw CDC guideline. They say either you can do Monto test or IGRA, and you will be surprised. IGRA is cheaper in America than the Monto test. The reason being, IGRA they have to come only once. Monto test they have to come and they can't afford to waste their time. So Monto test is very expensive. That's why in America they are using IGRA. But you have to do one of the tests. So rule out latent tuberculosis, because latent tuberculosis, there are 2 trials. Even the rheumatology trial, meta trial, where they say there are 4 cases of tuberculosis, but there they have only looked for active tuberculosis. They never look for latent tuberculosis. Latent tuberculosis, you have to give prophylactic, either Isonex for 6 to 9 months, or Isonex and rifampicin if you are given for 4 months.
And what are the
So you want to add
investigations?
anything?
What are the investigations that we need to do before we start tofacitinib?
Pardon?
Investigations that we need to do before we start tofacitinib.
See, before starting tofacitinib, first thing you have to rule out any active infection, especially viral infection, hepatitis, HIV, hepatitis B, hepatitis C, and of course, routine CBC, serum creatine, LFT. As Rohan said, the lipid profile is very important. You have to rule out, and then, of course, patients like lactating mother, of course, pregnancy or any hypersensitivity is there. We have to rule out this, and then you can, and chest X-ray, yes, sir, Monto test already I mentioned it. Rohan, you want to add anything?
No, sir. I think the list is very comprehensive.
Well, very interesting question, sir. As methotrexate gives wonder results in psoriasis and is very cost effective. So is it necessary that some doctor wants to know whether it is tofacitinib worth using over methotrexate, and whether it's an overhyped drug?
No, see, initially, because the methotrexate takes again longer time. Any patient coming with a severe, that is more than 10% body surface area is involved, methotrexate always you tell 1 month to 6 weeks for the improvement, while this drug is more effective, is more potent. So initially you can use tofacitinib and you can switch over to methotrexate.
I just like to add one point here. According to BAD guidelines, so they recommend starting immunosuppressant or systemics for anybody who is having either 10% body surface area or 10% PASI score, or anybody whose DLQI is more than 10. So in those kind of patients who is really distressed with psoriasis, so we can definitely go for an option which acts faster than methotrexate. So obviously the question is very right in asking that methotrexate is a cheaper option as compared to tofacitinib. But if the patient feels that that a faster response is what is important for his overall health, then definitely it can be a good choice.
Another question, sir. If there is a relapse cases of alopecia areata, how do you manage it?
I think you answered this. We already
Yes. In case of vitiligo, is tofacitinib monotherapy sufficient?
See, I'm conducting this CME program for last almost 3 years. After 1 year of experience, I started conducting across the country. And according to our dermatologist colleague, tofacitinib with UV narrowband therapy, the results are far, far better. That is the consensus across the country.
And the side effect profile is also better, sir.
Yes, correct.
And would the dose for vitiligo will be same 5 mg twice a day?
Depends upon the extension. Usually I
Extensivity.
start with a
Yes.
2 BID
Oh.
and then taper it. Yeah. But again, this point about the vitiligo, patients start showing improvement after 16 to 20 weeks,
Oh my
not
God.
before that.
So
At least
almost
4
3,
to
4
5
months.
months.
Okay,
Yes.
okay. That's
That's
very
true.
important.
That's very
Continuing
true.
therapy. Yes, yes,
Very
yes,
true.
Yes.
And most frequently should be monitored. Does tofacitinib increase risk of stroke?
See, they say there are cardiovascular, there are
Adverse effect.
some paper that cardiovascular risk can be increased.
Hmm.
But there is one paper they said is equivalent to what you are using the placebo or that's the reports are there. That reminds me about the malignancy. See, they have not mentioned to rule out the malignancy before only the history of malignancy. They're better not to start tofacitinib. But my experience, I've seen 4 cases of malignancy.
Oh.
One is a breast cancer after starting tofacitinib after 1 year.
Okay.
Another is a brain tumor I have seen. And these patients, we do not know, I did not rule out. But my suggestion is before starting tofacitinib, at least in the male, if there is no history of malignancy, ask history of lung cancer and the prostate cancer, which is very common, and the female breast cancer and the genital cancer. This you should ask and then you start. At least breast, you must examine breast. Yeah.
Sir, are these side effects more of dose related or duration related?
Both. If the dose related and the longer duration, but if you see my experience last 4.5 years, the dose is 5 milligram once in a week. Hardly there is any side effects. Hardly any side effects. Yeah.
One question has come now. Is ECG advisable in all or only patient with some history and age?
Can you repeat that question?
Is ECG advisable in all patients or only with some history or age?
Rohan, you would like to take it?
Sir, ECG is not one of the part of routine pre-treatment guideline for tofacitinib, according to most of the guidelines. But yeah, if patient has history of any kind of myocardial infarction or cardiovascular events in the family, or any kind of MACE, that is major adverse cardiovascular events, then definitely we should go for a thorough cardiac evaluation using an ECG. But routine ECG, I don't think it's recommended.
Yes, correct.
In psoriasis, another thing has come. Can we use methotrexate along with tofacitinib and for how long?
No, it has to be again the prolonged period, 1 year, 2 years, 3 years. It depends.
Yeah, depending on the severity.
Yes,
absolutely.
I think that's all until now. We had a very lovely session and lovely questions also. Thank you so much, Dr. Rohan, Dr. Saple. Thank you so much for spending your evening with us. Thanks all the doctor for participating. Thank you, marketing team Hitro, for conceptualizing this webinar. Thanks, IT team, for your continuous support. Last but not the least, thank you, Field Force of Hitro, for your efforts in making this successful. Signing off, a very good evening to all of you. Thank you so much.
Prashant, once again, I must thank first thing Rohan. Rohan, you have given wonderful your share.
Thank you. Thank you so much, sir.
Thank you for asking questions. I'm very much impressed about you. And
thank you so much, sir. Thank you so much,
in the tofacitinib. And then, of course, Dr. Prashant and their whole team of Hetero, their technical people, and I can't forget those doctors who are attended with us. I'm thankful to them also. Okay, and I think we'll retire for at least I am going for dinner. It's too late.
Yes.
Yes, sir. Thank you so much.
Thank you.
Good night. Good night.
Good night.
Good night.
Thanks, Giridhar.
Thank you, Prashant. Dr. Prashant, thank you.
Thank you, Giridhar.
Thank you, Sunday.